Hello, my name is Ben Wessler. I'm a cardiologist at Tufts Medical Center in Boston, Massachusetts. And I'm going to talk to you today about the upcoming study-a-thon and some background work we've done to motivate the work coming up ahead. By ways of introduction, I'm a clinical cardiologist as well as a clinical researcher. I regularly see patients and have a strong interest in prediction. And I can tell everybody that while there are hundreds of models available to predict outcomes for patients, I can count on one hand the number of models that I use on a regular basis because there is a huge disconnect between the number of models that are available and the number of models that we use to inform treatment decisions on a regular basis. This quote is one of the main challenges that we face as clinicians. Patients want to know, given my personal characteristics, conditions, and preferences, what should I expect will happen to me? This remains a fundamental challenge for patients, but also for clinicians and researchers who are trying to predict what will happen. Prediction models have been our answer. Prediction models are multivariable statistical algorithms that produce patient-specific estimates of clinically important outcome risks based on easily obtainable clinical and also laboratory data. And they help us, clinicians and also researchers, to answer this question of what will happen for an individual sitting in front of us. We have substantial interest in this and have studied these predictive models. Under the leadership of David Kent, here at Tufts, we've created a predictive model registry. This registry is freely available. We will share the link. And it catalogs predictive models for cardiovascular disease that have been published since 1990. We've made a few observations that are of interest to the community here. The first is an overabundance of models. Our registry has over 1,300 predictive models for patients with cardiovascular disease. And to show a few examples, just looking at predictive models for coronary artery disease, there are over 300 published models. And for models predicting outcomes in the primary prevention space, there are over 200 models. And there are approximately 150 models for patients with heart failure. On the right, we have a graph showing the steady increase in publications of predictive models over time. And they're stratified here by index condition. And you can see that there are over 100 models published each year ever since 2012. One of the keys to using and interpreting outputs with prediction models is this claim that it is often assumed that clinical decisions based on these predictions are superior to decisions made without these tools. Said another way, that they lead to better outcomes. And we have very little evidence at this point to support this claim. And in fact, recently we've demonstrated that this may not be true. Supported by PCORI, we've studied how well predictive models validate. We've taken all the models in our registry, over 1,300, and done a systematic search to identify external validations of these models. And the comprehensive look shows that there are over 2,000 external validations of the models that are in our registry. Again, these are predictive models for cardiovascular disease. Interestingly, though, the majority of these models have never been externally validated. In fact, only 42% of the predictive models in our registry have ever been externally validated. And while on average, there are 1.5 validations per predictive model, the distribution is extremely skewed, where there is a model that has 94 external validations, and there are many, almost 60% of models that have never been externally validated. Here is a table from the report we are putting together, which lists on the left the 10 most validated predictive models in the cardiovascular space. And if you move across these columns, in the far right, we have a listing of the range of performance. This is specifically discrimination that is seen in the validations that have been performed. And if we look at one model, for example, the additive Euroscore, which has been validated 86 times, the performance ranges from a C-statistic of 0.58, which is almost useless, to a C-statistic of 0.9, which is almost perfect. These observations are seen for most of the models that have been validated more than once and suggest two things. Number one, that there is a substantial range in performance of predictive models when evaluated in more than one validation database. And also that a single external validation is wholly insufficient to understand how trustworthy a predictive model is. These observations motivate the study-a-thon that's coming ahead. And in particular, we seek to understand how well two commonly used predictive models perform, and then also what updating techniques do to their respective performance. The first model is the Revised Cardiac Risk Index, which is a predictive model that is used to predict major adverse cardiac events after non-cardiac surgeries. And this model is used to inform decisions about preoperative clinical testing, as well as to enhance shared decision-making between the patient undergoing the operation and the surgeon and anesthesiologist involved in their care. The second model that we will be validating is the Pooled Cohort Risk Equation, which has variables that are shown here and is leveraged to inform a primary prevention treatment decision related to statin therapy. Now moving to the two specific aims of the study-a-thon. The first aim, to recap, is to evaluate the performance of two well-established clinical prediction models, the Revised Cardiac Risk Index and the Pooled Cohort Equation, across a diverse range of practice settings. These evaluations will assess model discrimination, which is captured by the C-statistic, calibration, which we will describe using the Harrell's E statistics, and net benefit, focused on clinically relevant thresholds. And aim two is to evaluate the improvements in model performance using simple recalibration approaches across these diverse settings, with particular attention to how net benefit changes at certain thresholds. Most of the folks listening to this talk will be familiar with discrimination, which will be presented as the area under the receiving operated curve, or the C statistic. This is a rank order statistic and identifies how effectively a model separates patients who experience an outcome from those who do not. The other domain that we will focus on is that of calibration, which broadly represents how predictions match observed event rates. And we will be focusing on describing this domain of performance using Harrell's E statistics, which represent the absolute difference between smoothed observed outcomes and the predicted probabilities. The work we're going to be taking on also focuses on decision curve analysis, which I'll review very briefly. Decision curve analysis presents an assessment of potential clinical consequences of using predictive models by examining misclassification of patients across a range of thresholds, while weighting the relative utility of false positive and false negative predictions. And we're going to focus on the study-a-thon on net benefit at specific thresholds of interest to the clinical community. And there are two. For the first model, the pooled cohort equation, the threshold of interest is a risk of atherosclerotic cardiovascular disease at 7.5% for 10-year risk. And for the revised cardiac risk index, it's a 1% risk at 30 days post-procedure. And we'll study how net benefit looks and how it changes after recalibration. Models can be updated or recalibrated in a number of ways. This is a table from Ewout Steyerberg's recent publication. And we're going to focus on two simple updating techniques. The first addresses calibration in the large and focuses on updating the intercept. The second updates the intercept and then also adds a correction factor to update the slope. And we will see how performance changes, specifically with respect to calibration and net benefit, with these two updating techniques. So in summary, these are the two aims of the proposed and upcoming study-a-thon. The first will be to evaluate the performance of these two models across a number of settings. And then the second aim is to evaluate how these models can improve with simple recalibration approaches, with particular attention to how net benefit changes. I'll stop there. I welcome any questions that may come over the next few days. And thank you very much for participating.